The Core 360 belt is the best aid to train the abdominal wall. The Core 360 is a patent-pending, first-of-its-kind training belt that helps you move, breathe, and perform better. We use the Core 360 belt with almost every patient at Winchester Spine and Sport. The biofeedback is second to none, and it's an amazing way to teach proper respiration and can be even used during higher-level movements in the gym. Teaching proper respiration is about as fun as a rash, but with the Core 360 belt, you take all the headaches away. Visit core360belt.com and use the code GESTALT for 10% off all belts, Ohmtrack sensors not included. Again, visit core360, core360belt.com and use the code GESTALT for 10% off. Enjoy the episode. All right, everyone, we're back for part two of our conversation with Gary Gray. So if you missed part one, obviously, go back. We talked all about assessment. We kind of introduced a lot of the concepts with function, how Gary's mind works with, or the Gray Institute minds works with assessment. And so now we're this is where the rubber hits the road. So we've assessed our patients. We got a good idea of the areas that we need to attack. And so we're going to start tackling treatment, Brett.
And I think a good way to think of this too is like if you're out on the athletic field, you never get the same never the same situation twice. Your opponents are somewhere, your teammates, sounds are different, the ball's in a different place. So I think that's kind of making an argument for we need to, assess all these different, planes of motion in our assessment.
No, I don't think you can say it better than that. Real function doesn't repeat itself day after day. There's a little different when I walk to school, if I have to, go around somebody, even swinging a golf club. It's totally different, a little different slant, a little different temperature, a little different pressure on me. And so that's why a big part of treatment in our mind's eye is what we call tweakology or variability. How do you make sure that you cover the 1,000 ways that I might have to juke somebody, as opposed to I'm just going to teach you this one movement and hopefully it covers all 1,000. It doesn't. So a big power of what we've come up with, and it's because of Doug's nomenclature, is the power of tweakology. How do you take a solid movement that they got and then gradually tweak it so they can handle anything that's going to occur out there in the wild blue yonder?
Right. And you coined a term. I'm assuming you coined the term driver. Is that?
We use it a lot. I think other people probably have used it. I think in the world of human movement, we probably coined it.
Right.
Because we kept asking ourselves, what causes the human body to move? And then Dave Tiberia would keep saying, well, what drives it? And I go, oh, that's better. Gravity drives it, ground reaction force drives it, mass and momentum drives it, our hand drives it, our eyes drive it, our feet drive it, our pelvis drives it, and our intent drives it, and our attitude drives it, and whether I'm encouraged or not. If I'm discouraged, I'm not going to get up off the couch and move. But if I'm encouraged, I might get off the couch and move. So what drove movement there was a behavioral driver. So
right.
Even if we talk development, if we're in a DNS seminar, the first year of development is basically, it's through
exploration of all the
emotional need, through all that kind of stuff.
Yeah.
So that sounds like that's exactly the transitions.
Well, why do we learn to walk? So I can get to my toy quicker than my sister.
Right.
If I can crawl there and don't have much competition, I won't walk. But if I see my sister getting there a little quicker, I'm going, got to be a better way to locomote. So I'm going to figure this sucker out. So those first 12 months are a miracle. I think what we've tried to do is study the first 12 months of life and try to reduplicate as much as we can, because I believe we're missing so much. I call that kind of developing the hard drive, and I think a lot of what I do and miss the boat is I do a lot of software work where I forget. Sometimes I got to clear the software and go back to the hard drive, clean it and restore it and give it a new opportunity, and then build the software. And I believe we get a lot of our hard drive knowledge, like you said, the first 12 months of life.
And I mean, the opportunity to drive a patient is it's basically infinity, isn't it? Because
Yes.
we could use, for example, like a foot driver here, but we could also drive them in the coronal plane, the transverse plane.
Yeah.
We could use our arms as a driver.
Yeah.
Before we started the actual podcast, we were talking about how you could use your eyes as a driver.
Exactly.
So all of these different things could potentially be used as a driver. How do you decide which driver to use?
We have a saying at the Gait Institute. I think of all our goofy sayings, this is the one that's going to stick. Because this is the one when people hear it, they go, Man, I wish somebody would have told me that years ago. The test is the exercise, and the exercise is a test. If you have the right test, everything you do after it's going to look like the test. If you don't, things are going to look different. You'll have what we call gaposis. And that's what I did for the first number of years of my career. I did these artificial tests, and then when I trained somebody, it didn't look at all like the test. So I'm asking myself, why in the world did I do that test? And the answer is, I have no idea. But now that the way you said it, the test is the exercise is the test. They did pretty good with this. Now I'm going to use various drivers and various tweaks to facilitate that in order to create a reaction I want. So, for example, you want to do your posterior chain real quick?
Let's do it.
So let's go back to your posterior chain, okay? Which foot did you put back? I think you put your right foot back, didn't you? Go ahead and do that again, just to warm up, okay? Come back, good. Go down again, good. And go to toe touch now. Just kind of go toe touch, good. And then go no toe touch, and you got your wiggles going on, good. And get your hands down a little further. You're doing wonderful, Taylor. Good job. Good. And so you see all the skittish going on there. Great. That's normal, especially if you get into that transformational zone, okay? So we might say, well, you're not going to kill yourself if I keep you in that plane. You have no pain right now. Sure. So I'm going to still use the hands as a driver, but I'm just going to go in a different plane of motion, okay? So what I'd like you to do is I'd like you to, instead of going straight down, I want you to go first time to the right, first time to the left. First time to the right, first time to the left. Just alternate for me. Go to the right, good, and come back, go to the left. Great job. Go to the right, go to the left. Okay, good. And go the other way, good. Now do me a favor, go just a little quicker. You're doing great, good. Good, now good. Now come back up, just kind of relax, okay? Now just do the first one you did, just go straight back. A lot less jittery. All of a sudden you're stable. You're like, well, how did you get me stable in less than 2 minutes? Because I just created a little buffer zone. Okay, to that, I added a little transverse plane. You still use the hand as a driver. I could have taken your foot in the frontal or the transverse plane, or I could have had you rotate your head one way or the other and use your eyes as a driver. But since you were pretty good with the hand driver, I thought, let's just go with it and see. Now, if you would have done that and not come back to better stability, I would have gone, hey, good day, Bob. In my mind's eye, I'm going, wrong driver, dummy, okay? And I might go to the foot, and I might go to the head. But it should smell and look a lot like the test. The best way to test somebody's jumping ability is, jumping, okay? And if you're going to train me to jump, it should smell a lot like jumping. Probably won't be on a table lifting cuff weights, okay? I'll probably doing a lot of things with the subtalar joint, a lot of things with the knees, everything in 3 planes of motion. So, and even things with the, like we said, with the tongue. And so I could load, and the next time I jump, I subconsciously jump higher. Well, how am I going to test if I jump higher? I'm going to go back and retest jumping. It's almost too simple when you take the complexity of AFS and you realize what we do. Our job turns into really simple because the patient's going to tell me what's wrong with them and the patient's going to tell me what's right with them. I just now start experimenting with tweaks and finding out what gets you there quicker, and it's very safe. And I go, wow, this is kind of fun. They love it because it smells just like what they want to do. So if you're a golfer, a lot of things are going to be done either here or here. You're not going to be on all fours. You're not going to be laying on your back, lowering your leg and seeing if you can contract your abdominals to have good core strength, because that has absolutely nothing to do with golf. So the beauty of AFS is it smells like the thing, it tastes like the thing, it looks like the thing, it is the thing, and the thing slightly tweaked will make the thing a little better.
You said something, you noticed that using my arm seemed like a good idea. Is there ever anything in your assessment, is that usually your first go-to? It's like, no. Okay. Or anything that would give you a hint is like, okay, this is the driver I'm going to use.
Well, interesting, when you just took your foot back, you had pretty good stability. You didn't have the wiggle. Okay, when I added the hands, you had the wiggle. So I'm thinking, okay, maybe the hands are going to be the best bang for the buck. If I was really strategic, I probably should have gone back, no hands, and just let you use a foot driver, come back, foot driver to get the hip to move a little more transverse plane, and then get the hamstrings functioning a little better in the transverse plane. Then I probably should have not even put the foot back, just gone hands here, and then put them back together. So in a very, if you were a patient and I had an extra 4 minutes and I wasn't trying to impress somebody on video, I would have probably used both drivers. Yep.
Well, and I mean, you could also be, and we didn't talk about this in the assessment, but you could be measuring the excursion.
Exactly.
I mean, if you had to put numbers, if you're being forced to put numbers to what we're doing.
Oh, yeah. You can do goniometric measurement. You can, I do what you say. I just measure how far they're able to toe touch and still come back home and feel comfortable about it. It's really easy.
Are you at all concerned? So like if I was just doing a coronal plane reach like this, like if I'm driving way out here, is there a point where you're like, okay, that is too much valgosity? We all know that pronation and valgosity is a normal thing in function. Right. But I mean, are we talking like, is there a functional range that's okay, or we're not, it doesn't really matter as long as it's controlled? And
yeah, well, you got to the nuts. I like that. You went right to the nuts, which is good. So where we really kind of got on the map back kind of late 70s, early 80s is people were having ACL tears, and everybody was saying, well, we want to do a preventative program, or we're going to do rehab so you don't tear your ACL. And we're going, Lord bless them. Okay, I didn't have kids yet, but I didn't want them to have an ACL tear. So I'm going, man, if we can figure this out before my kids get there, selfishly, that's good. And so the very first thing we did is and you hit it right on the nose, we noticed that everybody who came down and had severe valgus, which not only was valgus but internal rotation, if they went too far, they tore their ACL. So common sense says, probably don't want to go too far. We even tease now that announcers on TV can watch that happen and they can diagnose it before we do. The announcer will go, oh, I think they tore their ACL. And they're spot on. You know, next day reading the paper, they had an MRI and Susie tore her ACL. And it's like, it's so common that's like, okay. So the $1 million question is, what causes the ACL to tear? Well, too much valgus, or what we'd call abduction and internal rotation, but if you saw where the ACL lived, that lengthening there will get it to a point where it'll rip. Okay, so our hearts were in the right spot back in the day, because we said, well, if we can train people to keep their knee over their foot all the time, so it wouldn't migrate in, we can prevent them from having an ACL tear. And even though Pooh Bear would say, that makes no sense because I never see it happen, you know, some of the greatest athletes show you 30 degrees of valgusing or abduction of the knee, and they explode and they're doing well, and you want to take that away. And we were saying, well, theoretically though, if you never get there, you're not going to tear it. The problem is that motion, that basically is the distal hip. Okay, this is the proximal foot. And so this motion turns my butt on in the transverse from the frontal plane to make it powerful. And this motion turns on my calf and my posterior tib and my peroneus longus. So without that motion available at the knee, I've just taken away the strength of the foot and the hip. So even though our heart was in the right spot, we're coming about it totally wrong. We had to ask ourselves, is it normal? And as you just presented it, you actually did a brilliant test for that. I would get people who were trained very non-functionally, and the very first test I would do on them is the one you intuitively went to. And here's what you did. You did a toe touch test out here, because that drives the knee in. Okay? And what would happen is, if you never learn how to train your hip and your foot, you would do this. You would go into varus immediately, because that's the only stable. Because they wouldn't let you do this. They wouldn't let you internally rotate your hip or evert your foot or pronate your foot. And so that was a dead giveaway. We got a little work to do. But the key is, that is normal, okay? However, if you see somebody maybe drive their foot in the sagittal plane and it dives in, you're going to scratch your head and go, wait a minute, I didn't drive you in the frontal plane. Why are you moving in the frontal plane? And then the hip and the foot's going to say, I have a problem. I'm glad you saw that. So doing what you just did, I want it to go as far as it can go. I mean, if you can show me 40 degrees of abduction, toe touch here, and you can come back home, I'm happy as a lark, because that means you really can turn your butt on. Where back in the day, and even some people now go, oh. No, it's if I'm reaching in the sagittal plane and now my knee dives in, I probably have a forefoot varus, or I probably have a foot that can control eversion, or I have a weak hip. Because now when I'm doing this, it dives in, and I'm going, okay, I don't expect that to happen. And worse than that, if I'm crossing over and I expect adduction, the thing still dives in, I got to back off and say, okay, I got a little work to do here. So I love the way you presented it, because is it normal? It depends on what you're doing. Depends on what driver you're using, what plane of motion you're driving in, how aggressive you're driving it in, what kind of surface you're on, and what we'd expect. If we expect a lot of valgusing or abduction, good to go. If I don't expect it and I see it, I got to step back and go, why? And I'll give you a hint. It's either the foot, the hip, or the thoracic spine. It's
Right.
pretty easy. Yeah.
And then, so let's say we're dealing with structural ankle equinus, where we
Yes.
just don't have dorsiflexion.
Yes.
So, and then, so now when we're wanting to move in the sagittal plane, they're now being forced in the coronal or sagittal plane. So how do you reconcile that when you deal with a structural abnormality in the body?
Now you just hit the hardest part of the job, okay? Because the hardest part of the job is trying to discern if something's purely functional or purely structural, which usually it's a hybrid of all. But like you said, it's really easy to see a real high-arched ankle equinus structural foot. You can, put 1,000 pounds on it, ain't going to dorsiflex.
Right.
Okay, so you go, crap, do I keep trying to force that? Because as you said, it's going to cheat in the other two planes. The lack of ankle dorsiflexion walking, I'm going to retract my right hip, and I'm going to have a right L5S1 facet problem, guaranteed. And then the other part of that is not only could that be a structural problem, but as we get older, is the joint so worn down that it's kind of pseudo-structural. In other words, it's so arthritic, I'm never, I'd have to go through 18 spurs to get the ankle dorsiflexion back. Let's say I have a spur on my talus, and I just go, okay, it's not structural equinus, it's just a worn out. So I have to fight around that. And that, again, I think is the beauty of AFS, because with the power of tweakology, we can work around it. We have to work around it. Because if a person says, I still want to walk, but I don't want to have back pain, we got to figure out, well, how do I get you over that foot that doesn't have any dorsiflexion without retracting your pelvis and smacking S1 against L5 every time you take a step? How do I cheat that? And that's where the power of tweakology comes in, or the power of a heel lift, or the power of an orthotic, or just understanding your foot biomechanics and saying, there's not an exercise in the world that's going to fix that. Just put a couple heel lifts underneath them and they'll get over it and they'll go home without any back pain. So that's where this becomes, the challenge is, you just hit the biggest challenge for me, is how much of this can I help them with some manual therapy or some exercise therapy or some advice, and how much of this is structural that we're going to have to use something entirely different that they don't have control over. That's hard for me.
Well, I think the beauty of the assessment basically got you to that point. You're able to see it, and then you're basically just kind of whittling down what the possibilities are, and then eventually you get that through the assessment.
I like that. Really, when you think about that, we're whittling. You look at the whole thing, but then you just kind of whittle down the possibilities, and believe it or not, it becomes to some significant, consistent patterns that you see with people. It's not as complicated as you would think. If I have to know what every joint in this body is supposed to do for every functional activity, which we kind of do, that's daunting. But as Ryan knows, it's a whittling.
Right.
That probably not that, probably not that. Look how good they did there. That's probably, oh, look at there. I didn't look at that other foot. Oh crap. If I fix that shoulder is going to be a lot better really quick.
Right.
So that's where it gets fun.
I say
it's whittling. I like whittling.
Yeah, that's good.
It's a fun word.
Yeah.
I say the words load to unload.
Mm-hmm.
What would you say back?
I love it. I would say it's how the body functions. The body will load into a transformational zone, we call it. Now, we did make that one up. But then in order to unload. And so if I jump, I can certainly jump by staying here not loading, just try to unload. But I'm not a very good jumper to begin with, but I'm going to be really poor if you don't let me load first. So I'm going to load, and then I'm going to unload. Okay, what am I loading? Everything. Okay, watch some of the greatest. Those of us who are kind of now old enough, you can watch NBA game anytime. But Michael, he would load so beautifully in all three planes of motion that when he unloaded, he could actually load in the air and change direction in the air. I don't know if you remember the one layup he made. But back on the other side. He took off and you're going, yeah, he's on the right side of the basket. While he's in the air, he goes, no, I'm going to go to the left side of the basket. You go, okay, timeout. Well, volleyball players do that too. They load in order to get up. Then they have to load again in order to explode and hit the ball. So the ability to go into a transformational zone to load is really 95% of what we evaluate now. In other words, do you have the motion to turn on the proprioceptors to get the muscles to load so they can explode and you can be efficient? If not, I can guarantee you I'm going to spend most of my time there. So this is the transformational zone of golf. Okay, you'll see me spend 95% of my time there. The only other place you'll see me spend more time, follow through. The rest of it is I have no control over. because this is the load, this is the explode, this is load. If I'm a big lefty, here's pitches per load, come out, explode. I'm loading again as I decelerate, and as I decelerate it here, so I go, how well do you load and explode? And it's, you look at any book and it'll show you the EMG activity, and you'll see this, zoom, everyone, load, explode. Load, explode.
And there's a baseball expert who's now deceased, but his name was Charlie Lau, and his famous statement was, you have to go backwards to go forward with pitching and hitting. And that's essentially the quality of your load.
Yeah.
Right?
It is the quality of your ability to go back, what joints you can load and what planes, to turn on as many proprioceptors as you can, because the more proprioceptors I turn on, the more muscles that can explode, the better, higher I jump, the faster I'll throw, the better I'll hit my forehand, the better I'll walk. Walking is I load, okay? If I didn't stop the load, I'd fall on my face, I load and I explode, and then all of a sudden I load, this hit, and I explode. So walking has two transformational zones to it. So you'll see us with applied functional science, we train in transformational zones. Makes our job real easy, because there's no reason to train anywhere else. So we do mobility, stability, strength, power, balance, manual therapy. Everything is in a transformational zone. We don't do it anywhere else, because that's where I need the motion to turn on the proprioceptors to get them to move better. The goal is to get them to move better. This gets to be a pretty easy job.
Yeah. Let's peel back to something a lot more boring than golf or throwing or hitting, which is walking.
Sure.
And so we have a transformational zone too, as you said, in the gait cycle. But I think, what people sometimes don't realize is we do need both functions of the foot, that being pronation and supination.
Yep.
But to get supination, you actually have to have pronation to set you up for that supination. I think it's so binary for people. They don't,
You're a
realize
supinator
it.
or a pronator. There's no in between.
Exactly.
No. I don't think I'm not going to repeat that, because I've just.
Okay,
Can't say it better. I'm sorry.
Yeah. So, but
how come he says things better than me?
No, I do not. But so if you in saying that, so because we're going to get together again in October, and we'll talk about that in a second. So one of the things we'd be looking in a gait evaluation would actually be whether or not those transformation zones are actually occurring.
Bingo.
True. And then kind of like you said, you gave credit to your wonderful son Doug about using the term tweakology.
Right.
So we can watch a patient, do their normal walk in the sagittal plane, and then we can also tweak the gait to kind of maybe pull out some things that we might miss because human walking is a very mid-range movement. So sometimes it's kind of hard to see the compensations, but we can tweak the gait to maybe help us as clinicians maybe find where we would want to input ourselves into the equation.
And in this case, the way you're tweaking is brilliant. You're just forcing them to go to the end range so they expose themselves.
Right.
Yep. Very good.
Yep. Okay. So in human walking, what are some of the tweaks that we'll kind of tease the seminar a little bit. What are some of the we can do toe in, we can do toe out, we could do Groucho walking. I don't know if that's what you call it, but we got some different ideas for that. Yeah.
Yeah. The cool thing to understand about human walking is that in transformational zone 1, where we talked about all those things that gravity causes, gravity causes all those. There's no muscles that cause that. So if somebody says, well, I want to get your hip stronger in adduction, I'm going, you better not use the adductors. You better use gravity. And then you better use the abductors to get loaded while it's adducting and explode. And they'll go, whoa. Never thought of that. So all the motions that we went through in that first part are given for free. Money for nothing, chicks for free. Okay. So if anybody comes up with the date and then that one, they get an extra bonus point or a free certification or something, because that's an important song. But the cool part is then, and this is where it gets really fun. And so in Gait, I'll always kind of tease some of the physical therapy students who are just getting ready to be physical therapists. I'll go, in Gait, what is the function of the abdominals? And they'll look at me like, no one's ever asked me that before. In Gait, what's the function of the sternocleidomastoid? They'll go, in Gait? I go, yeah. In Gait, what do the rhomboids do? And they keep looking at me, and pretty soon they're going, okay, obviously we don't know the answer. The answer is to invert the heel. So the question is, what did you just say? And eversion or pronation, like you properly said. The proper word's pronation because it's a triplane thing going on, but we use that frontal plane component of eversion. That's given for free. The thing that ultimately inverts the heel to lock up the mid-tarsal joint to allow me to propel and allow all those good things to happen upstairs and let my back be healthy is inversion. But when you think of a power and the force that creates eversion, ground reaction force, mass momentum, 2.5 in running 5 times body weight, what muscle am I going to use to invert the heel? And the answer is every one of them I got.
Right.
And so literally when I walk, the reason my pelvis goes one way and my trunk goes the other way, so I can lengthen my abdominals, so I can grab this pelvis here and I can bring it up and it can help me invert my heel. So the function of any muscle in the body during walking, one of the functions is to assist all the muscles that are closer to the foot to invert the heel.
Right.
Most of us probably didn't put that on our state boards. You know,
Right,
it's like,
yeah, right.
wait a minute, where'd you come up with that crap? And it just makes sense. You know, it's like, yeah, the reason I'm swinging my arms is so I can walk, and the whole inversion of the heel is important because that's what locks up the mid-tarsal joint and makes it stable, which we'll talk a lot about at the seminar. I think that's key. But the key is the exploding is all muscle function. The loading is usually mass and momentum. There's a little bit of it, like golf, I have to pick my hands up. In baseball, I have to take the ball back, go the opposite direction. But 95% of loading is given for free.
Right.
But can you grab it and can you show it to me and can you decelerate it and can you come back home and show me the explosion I want for that particular activity? That's the $1 million question.
In the running world, they use a term called dwell. Mm-hmm. Dwell basically means like the time of the load.
Beautiful.
So I guess, are you looking at that too? Like
Sure.
to see like how quickly they're able to, react in the zone of
Yep.
transformation?
Yep. So one of the fun things about 3D maps is that if you look at 3D maps, you got to ask yourself, does that look like running? No. Does that look like golf? No. Does that look like anything we do during the day? Not really. Has components of it, but it's just the foundational pure plane motions. So what we then do is with 3D maps is we say, I'm evaluating a runner now. Okay, well, I can watch them run. My eyes aren't that quick. I can videotape and slow it down. That does help sometimes. But I'd like to see the same thing. I'd like to force them through maximum motion. So let's take the anterior chain of 3D maps. Okay, does that look like running? No. Only if you're doing a sprint and the ribbon's there and you're in first place. And I've never done it. I've never been in first place any race. But in running, when my pelvis goes forward on the right and relative back on the left, or what we call left rotation, we know that our arms drive our trunk the opposite to load the thoracolumbar fascia and the abdominals to invert the heel, amongst other things, but invert the heel. So what we do is we take 3D maps and go, well, when you do your anterior chain, don't put your hands over your head. When you do the anterior chain, what I want you to do is I want you to drive your left hand forward and your right hand back. So if you saw me do this, all of a sudden that starts to smell a lot like running. Running has more mass and momentum than 3D maps. So how do I get that? Well, I'm going to add the posterior chain. Pelvis is going to the right. Now my hands are going to here. So now I'm going to do this. So if you came in here right now and you saw me doing this, just across the way, you go ahead and let it go. It looks like you're halfway to running. Just let it go. And I'd go, well, I'm just kind of getting my left side ready to go to run. And then I'd go toe touch, and then I'd go no toe touch. And you'd go, well, that's brilliant. What a great way to assess running. I wonder if you do that in the frontal plane as well. Yes. I wonder if you do it in the transverse plane as well. Yes. Does that strengthen the muscles proprioceptively the way you want the muscles to be strengthened for running? Yes, because it loads and explodes. And it tweaks in and tweaks out. So I can see for a runner whether or not you have the ability to get there and to load and explode or not. Because if not, then I got to go, I wonder why in this case. The really cool part about any type of function, and we're learning this with walking and running, is that in every form of functional activity, there's a thing that we call proximal acceleration. All that means is if I'm a golfer and you see me here and I initiate the downswing with my hands, I'll play you for money. So if Taylor goes, let's play golf, and first of all, if I said that right foot roll out like you saw, we'll play for big money. But if he keeps that in, but if he starts the downswing with his hands, I'll go, like, what do you think, $50 a hole and do it, $100 a hole? But if I see him go here, okay, and all of a sudden accelerate with his pelvis to lengthen everything even more, and then let the hands passively come through, I'm going to go, let's just play for pride.
Yeah.
Okay, pride's cheap, and it's no big deal. Pitcher, gets here, first thing they do, they throw their pelvis to the plate. Punch. If I'm going to punch you, I can punch you, but if I do that first, so the 1-inch punch, if you watch him real quick, what he did is he loaded his right hip and he exploded his hip and then he knocked somebody out. It wasn't that he punched with his arm and his shoulder, he punched with his butt. Walking, we see the same thing. It's really cool because when you get into this transformational zone, like Brian said, now there's not just rotation, but there's a translation of the pelvis forward, a translation of the pelvis to the right, and a translation of the pelvis. We got a downward translation, a forward, and a sideways. So we got 3-axis translation. What that does is it loads it even more. So if I get that good translation, I'll explode passively. It'll be very easy. If I get here and I'm dead in the water and I don't have a good load and I have to pull with my leg, I'm going to walk very laborious like most of us do. Like a lot of runners, you just see that they're plodding. Okay, they're plodding because he hasn't got his hands on them and going, okay, you got your rotation, but you ain't got your translation. I'm going to give you your translation back. So the 68-year-old runner, he's lost foot strength, but I guarantee he's lost some translation because the translation, the best way to say it is if I have a slingshot and I pull the slingshot, that's load, okay? If I let go, that's explode. Makes sense. The rock's going to go hit you in the nose. But if I do this, and at the last, right before I let go, I drive my hand to your nose, look how much more explode I'm going to get. This is the pelvis moving towards the target. So anybody that does any sport, tennis players, dancers, jumpers, down linemen will tell you, I get enough buffer zone in my pelvis that the first thing that I come out of my stance with is my pelvis. I don't stand up or I don't go at you with my trunk. I let my pelvis load me and my body almost automatically springs in you and knocks you over. It's like, well, that's pretty cool. Now, did we make that up? No. But we saw it happening. And so a lot of what we do in treatment now is to make sure that in that transformational zone, you come out of that transformational zone with your pelvis first in all 3 planes of motion.
In hitting, you'll watch all the
Bingo.
best power hitters right now. It is so fascinating to watch. The first thing they'll do, pitch would be coming, and you'll see them take their hands back like this, and then they'll intuitively, they'll rotate their pelvis like this, take their hands back, and they're essentially, you'd call it loading, I would say creating pre-stretches, but same thing.
Same thing. Pre-stretch is better.
Well, and then
it makes more sense, yeah. I like it.
In the golf, the things you were saying earlier, so as I bring the club back, if I can keep the load and eversion, that's basically going to keep this home. At that point, I'm just basically rotating over a y-axis here.
Bingo.
And then if my shoulders are rotating faster and further than my pelvis, some call it X factor, we are eccentrically loading these muscles. And that's like the slingshot that we're talking about. You know, so I mean, how it all comes together, I mean, it keep you up at night. Well, and I mean, like when you just think about like how,
what's
because you can palpate from here too, you know, like this transformation zone. I mean, you could see like where, you know.
If you're a golfer and all of a sudden I go into my chiropractor and I say, not only do I want my low back pain to go away, I just want to hit the ball a little further. And you take me through 3D maps, and then you take me through, we have 3D maps for golf. There's 4 more motions, okay? Watch this. Backswing, strong backside hip, okay? Backswing, front side hip, follow through, front side hip, follow through, backside hip. Now I know everything about you. So if I'm behind there and I see what you're doing, what you can and can't do, I'm in love with you because it's the first time I ever went to a practitioner that let me look like I'm golfing. Most people lay on your table and say, well, let's see if you can do a sit-up, or let's, like, no, I'm a golfer. I stand up. I swing club. I go into transformational zone. I explode out of a transformational zone. Hands come through passively. Some stories I tell, these, I embellish a little bit. Hard to believe.
I do the same thing.
Yeah. But, and as you get older, what you have to do is go, is that really true, or have I embellished that my whole life and it's such a bad, I forgot, which could happen to me, I think.
Or do what my dad says, stop me if I've told you. Yeah, we've all heard it a million. And he's going to railroad that
Doug's
thing.
over there going, oh my goodness, like the 83rd time. But I remember when my kids first wanted to start playing golf, I'd never played golf. I grew up in a neighborhood where we couldn't afford golf, and we just didn't know what golf was, So when they decided to play golf, I think, well, yeah, I want to be a good father. I want to play golf too. So I thought, I should be able to figure this stupid thing out. I don't want to look that bad in front of my kids. And I'm guessing now, but within the first month or 2 or 3 months that I'm kind of learning how to swing the club, I'm at a course, and a lady that's 110 pounds, about 5 foot, says, hey, can I, would you mind if I joined you? Because I was by myself, and I'm rolling my eyes and going, oh boy, this is not going to be fun. You know, we're going to have to wait for her forever. But being a polite person, I go, well, sure, you know. And as you already know the story, by the fourth hole, she was out driving me by 60, 70, 80 yards. I wanted to take my clubs and throw them down and wrestle. I know I'm tougher and stronger than you. There's no way you should
Let's arm wrestle.
Yeah, let's arm wrestle. But the beautiful thing was, when I understand it now, I didn't understand it then, she would go beautifully in the transformational zone, pelvis would come out, everything would follow very passively, club head speed, go very fast, ball go deep. I'm trying to overcome the thing, and it's not working. And so when you see movements, we call them athletes, but where they don't even look like they're trying, and it's a thing of beauty, it's like, that's what I need for my patient. That's what I need for the 85-year-old. How are they doing that? And so at Gray Institute, we study how the body really does it, and we try to reduplicate it as best we can. That's all we got going.
In a world where everyone's trying to be sport specific,
right?
Sounds like that is a huge tenet of not only your assessments but also your treatments.
Yes.
And so maybe let's ask a different question here on treatment. When do you take a hands-on versus hands-off approach in treatment? So there's obviously a soft tissue component with the Gray Institute. There's a soft tissue course. Yeah. So talk us through in your mind what in your assessment drives you to put hands-on versus hands-off.
Well, here's the embarrassing thing. I used to teach a lot as I go back into the annals of what I've taught since 1976, I realized that probably 95% of what I've taught has been wrong. Okay, but luckily I've been around friends who say it's okay to be wrong, change your mind, you know, and don't ever admit that you were that bad, you know. So but one of the things I used to say very early on is that I think I understand chain reaction biomechanics so well, I can connive any environment to get any motion at a joint to happen. I couldn't have been as far from the truth as possible. And let's use the subtalar joint as an example, okay? I can put you on a round board and wiggle it. I can put you on whatever. I can put you on a slant. I can put you on the true stretch. I can do this. But not until I grab you and just move you nice and easy do I get that full motion that I want of eversion.
Right.
And so every place, obviously chiropractors have known that throughout the body, especially the spine. The spine can hide all kinds of things. That's why we get gunked there, and that's why we need somebody that can put me on a table and do a joint assessment and then say, let's do that again standing. But if I can give you a couple degrees of motion here in the thoracic spine, I'm going to take a tremendous amount of stress off your low back. Here's the answer to the question. I think we got to get our hands on people 10 times more than I ever dreamed, because the body will follow a path of least resistance. And the quickest way I can train the body to do what I ultimately want it to do, teach the proprioceptors, is get my hands on somebody and guide them through that correct motion. Key phrase, correct motion.
Right.
So for example, let's go golf. I know people are going tired of golf, but it's pretty easy to see and smell if you're driving your car, listen to the podcast. So before I'd let you do manual therapy on me, I'd say to you, my backswing transformational zone isn't complete. You took me through 3D maps. You have suspicious it's my left hip. Okay. Before you create motion on my left hip, you got to tell me what 3 motions you're going to create, and then you got to tell me which bone's going to go faster before I let you touch me. Because the only reason you would manually do therapy to somebody is to reinforce, normalize motion. And so if you can't tell me what normalized motion is first, I wouldn't go, well, I'm going to do a concave convex, or I'm going to do a thrust, or I'm going to do this of your hip, and go, no. I want to golf better. Okay? And you got to tell me that in the transformational zone, you better give me more abduction, you better give me more external rotation, and you better give me extension, and it better be the pelvis moving faster than the femur because it's hand-driven in all 3 planes of motion, or I'm not going to let you touch me. Now, that's a little dramatic, but that's what we believe at Gray Institute, that functional manual reaction is manual therapy specific to the joint motion for that particular activity, which is the game. And believe it or not, and I think Brian will tell you this, it makes it easier. What do you want to do? I want to walk better. So he immediately goes, well, let's look at the transformational zones of walking. Okay, I can give you a little more motion here. I can give you a little more extension, abduction. I give you a little more internal rotation, give you a little buffer zone there. I can give you a little more flexion, adduction, internal rotation here. I can give you more relative thoracic right rotation. I give you a little bit of lateral flexion to the right lumbar spine, lateral flexion to left, so a little type 2, type 1 motion. I can do that. He can do that with the hands. Next time I walk, I go, what the heck did you do to me? I'm walking so much better. You just took my limp away. My stress on my back went away. What did you do? And he's going, I reinforced the motion in the joints that they need to have to walk. I'm going, oh, that's brilliant. Okay, it's not brilliant. It's just chain reaction biomechanics.
Well, and I mean, if it weren't difficult enough, if we go back to the example of golf, the timing of the rotation is so critical for everything you're talking about. So if I'm bringing the club back like this, you'll see all the great rotational athletes. What they'll do different than everyone else is by the time I start to initiate my downswing, I actually have to initiate this support. Top 1,000 players in the world will do this. Yeah. So then to do that, then that means I haven't rotated early. So if we look at baseball hitting or golf.
That's really well put.
That's a fatal flaw. The fatal flaw is because if I start my downswing and I haven't initiated the support, I've now lost all that stretch.
You got it.
So I think what makes it so difficult, the people who move their body really well in rotation, they don't rotate soon. You said something earlier that really made me think about it. Golf is so you just want to get there sooner.
Sure.
So basically that is one of the fatal flaws of the golf swing, but all rotational sports. And it's kind of nice how it all comes together like that.
Oh,
it's
when
crazy.
it's done right, it's a thing of beauty. Here's the beautiful part though. We can take us old people and just restore some normalized motion to the pelvis a little bit and give them that back, because you don't consciously think about letting your pelvis take off. It happens, okay? So, but if I don't load and I don't get a good load here, my right hip isn't going to quickly say, get that force under that left foot so you can pivot over that so you have a nice post up to hit the ball. That happens all subconsciously. So if you don't have a good load here, I'm not going to have a good explode there. So Brian would give me a good load to this right side in all three planes of motion. Automatically, subconsciously, my body would say, well, you're fully loaded, let it go. And this would take off before my hands took off. I would start posting up, and all of a sudden the 80-year-old comes in and says, how can I get 20 yards further with my 7-iron? I went from 110 to 130 with my 7-iron. What did you do to me? And you say, well, we created a little more motion in that backside hip, gave you a little more posting ability, gave you a little more what we'd call stability on that front side so you can do that. But your body automatically is creating a whip, and a whip's going to hit the ball 130 yards instead of 110 yards. And your home exercise program is proving that. So I'm really proud of you, sir. We're just going to keep it up. And that's why we get excited, because it's not just the multi-million-dollar professional athletes that get better. It's the kid who just wants to play the violin. It's the older person who just wants to take a walk with his wife and not have to say, sweetie, I can't go with you today because I'm beat up. That just wants to live a quality life by the time they die. So that's the exciting thing about AFS, is we can look at anybody at any level of function and going, hey, understanding how that really functions, we can kind of go from there. A story I always tell, and it pisses PTs off mostly, but I say it to piss PTs off. But so I always tell a story of me driving my car, and I know nothing about how the engine works, but I do know when that little heat gauge starts going that way, and I see heat coming out of my engine, and I hear clicking going on, I know I got a problem, okay? So bad news is I can't go to a gas station, because there's no auto mechanic at gas stations. They have pizza. They have, lotto cards. They have everything but an auto mechanic now. In my day, you could pull up and the guy would go, hey, I'm going to wash your windshield and, put the gas in. I'm going, where's this guy at? But so you got to go to an auto mechanic shop. So I did that. I went to the auto mechanic shop and I pulled in. I got out of my car and the guy was there, a real nice guy. He had the cute smile like he has. He's got a good smile too. Do you smile like that all the time?
All the time.
It's like, I'm smiling. I'm happy. You could probably kick me in the shin and I'd go, that was fun. Let's do it. Hit me again.
Call him Mr. Smiley in our town.
Is he? I mean, it's awesome. Yeah. And he has that same thing. He's got, although his looks a little more conniving. You know what I'm saying? He's got. So I go. The guy goes, man, I'm glad you got here. So he's out there and he goes, oh, Gary, put your hand on the hood. It's hot. And he goes, hear that clicking? I go, I hear that clicking. And he goes, you got a problem. I go, I know. That's why I'm here. And he goes, do me a favor, get in your car, turn the engine off. I'll fix it. So I go and turn the engine off. He puts my hood up and doesn't check the engine or anything, doesn't grab any belts or anything, just kind of looks and measures the width and the length of my engine block. Goes into his little shop, he takes a big knife out and he cuts a piece of 6-inch dense foam, that exact shape. I mean, exactly. 39 inches wide, 42 inches long, same size as my engine block. He takes that thing and he puts the foam in this side, clicks it in here, makes sure it's padded down, takes the hood, snaps it down, says, Gary, do me a favor. What's that? Go start your car. Really? Yeah, go start it. Okay. Well, you're the expert. Okay, so I started. Come out. Let's wait a bit. Yep. What do you feel? No more heat. What do you hear? I don't hear the clicking anymore. Good to go. And as I'm driving out, I go, did I just get a hot pack ultrasonic massage? I did. No one fixed my engine.
Yeah.
You just can't hear it anymore.
Yeah, I just didn't hear it anymore, and they put enough buffer in there. I couldn't feel the heat yet. It's going to come, but that's what happened to me. My first number of years of therapy, living in a small community, I'd discharge patients that were fine. I'd run them to the mall. They weren't fine anymore, and I'm going, crap.
I've got the same story.
Yeah, I call that mall phobia. Scared to death because I'm going to run to all my failures. And when you live in a community long enough like me, I keep running into all my failures.
Oh, yeah.
Actually, I took my pants to get them fixed by this lady yesterday. Sweet lady. She goes, remember me? And I go, trying to be honest, I go, no. She goes, well, you saw me back in 1983 or something like that. I go, okay, my memory barely goes to 2013, but we'll go there. And do you remember what you did with me? I go, no. But I knew she was going to say, and since that time, I've been worse. And so I don't want that to happen anymore.
Right.
I'd rather treat the cause of the dysfunction and then maybe help with the dysfunction than the symptom a little bit. But at AFS, we believe that most of the pain is totally different place than where the cause is.
Wow, what a good thing! What a good thing.
Well, and it's something. It's a theme of kind of our podcast, and a thing that we're starting to realize with these high achievers, people that have built. I mean, look at what you've built. You have to be pretty proud of you and your family, of the Gray Institute, and all this stuff in little Adrian, Michigan. And we were talking off air. It's kind of cool. You could have been in Ann Arbor, you could have been in Detroit, you could have been anywhere, but you chose to kind of stick around here and to build this empire here. And it's something that we love that theme of being in Troy, Missouri. Sure. We've had Gray Cook on here. He's in Chatham, Virginia. You can kind of go down the list of all these like cool high achievers that are kind of building it. And so anyway, I just think that's an awesome theme. And talking about hooking up with your failures at Walmart and stuff like that. I mean, Brett and I, even me, I've only been in practice for 3.5 years now, and I've got 1,000 stories about it too. So I think that's just part of all of our journey is to try to get better and then meet those failures and see if you can help them now.
Yeah. You can't be cocky in our field. If I see a charlatan on a stage on a weekend who's cocky, they're not getting their nose broke every weekend.
No, it's. I'm in my devotions, I'm trying to pursue humility, but just treating patients keeps you humble. Mm-hmm. I mean, because we're not in charge of the healing. I can't heal anybody. I can't save anybody. I can't force anybody to learn something. All we're trying to do is create environments where, the healing will take place. And man, we just sometimes, most of the times, don't get them to where we want them. And it's humbling dealing with what we deal with because the human body is such a miracle. And then sometimes it's so rewarding that somebody does get a smile and they think we might have had something to do with it. I usually kind of get a grin on my face, and so, well, you did all the work, but thank you for letting me help you. So it's a fascinating opportunity we have, a privilege we have as chiropractors and physical therapists and strength coach and athletic trainers. It's a privilege. People come to us and say, "I'm broke, fix me."
And this superstar, Brian Rayfool, last year at our Gait seminar for MPI, he says, and we have Tom Michaud's there, I did a part, and then our president of MPI, Dr. King, did a part. In the middle of it, he's like, we got to get Gary here. So this coming year, the last weekend in October, we call them a fusion, where we're basically bringing these great minds together. So it'll be Thomas Michaud, who wrote this wonderful book, Human Locomotion.
It's a great book, by the way.
Yes, Gary Gray had it on his shelf, of course. Mm-hmm. Ironically, this is the book I learned from 20 years ago. This was one of your original books. And walking by your closet there, I saw the functional video digest, which I have like every single one of them, basically. And so it's going to be a really special seminar to bring a bunch of different things together. And we're really, really looking forward to that. So that'll be the last week in October. And
motionpalpation.org for more information there. So, yeah. It'll be awesome. DNS.
What's the .org? What is it?
Motionpalpation.org.
Beautiful.
Yep.
Gotcha.
So we'll put a link in the show notes and stuff like that. But we'd love to have you out there. It's such a fun weekend.
It's going to be a huge seminar. It'll be enormous.
And we've had some good conversations about some of the stuff in Tom's book, and we've had Tom on the podcast twice now. And so the cool thing about Tom is once he learns something new, holy smokes, then it changes his paradigm. And we love being around people like that. Just from this conversation, I can't wait to get back. It's Monday, or it's Tuesday now, I guess. So Wednesday, when we get back to patients tomorrow, to start applying some of these things and that kind of stuff. But
one more thing on this. Yeah. It'll be a 3-day seminar.
Yep.
So Gary will have a day, Tom will have a day, and then I'll have the third day, and Mark will be kind of injecting himself throughout the weekend also. And then what we're thinking about is we're going to like at the end of the day, maybe have like a little breakdown and kind of, that way we can incorporate everything that we're learning. And then at the end of those seminars, it's always nice because like I feel like you learn a lot about what someone's doing, but then you also learn how to mix and match some other things.
Yeah.
So it's going to be
That is the
special.
fun part.
Yeah.
Yep.
Definitely. So let's give the Gray Institute a little plug. So obviously 3D map sounds like a must take. That's a good starting point for anybody to gain the assessment. Then at the other end, we have the GIFT program. So tell us a little bit about the GIFT program and what that all entails.
Well, I don't even have to say much about the GIFT program. I can just point to this guy and just tell you how proud I am to be on his team. Like I said, the first time he wrote me a note about a patient, it was amazing because he documented in a way that I understood what was going on with the patient. I literally could see them in my mind's eye, and I'm thinking, wow, that's beyond brilliant to be able to assess somebody and to then articulate it in written word, and then to be able to apply the strategies of what we want. And so the evolution is, doing seminars and then doing books and then functional video digests, and finally people said, well, we want more, and we're going, man, I don't know what else we can give you unless you want to hang out with us for 40 weeks. And they're going, yeah, let's do that, and so we started, Dougie and Dave Tiberio and myself, and of course our amazing facilitators. We started this 16 years ago, and it's exceeded our expectations because, first of all, I get the blessing to meet new people and get to learn things from everybody.
Right.
It's actually the biggest con in the world. You're paying me to teach me, and it's like, this is brilliant, So you're willing to pay me money so I can learn more, and it really is, because we all learn more. Hopefully, we disseminate it well. But it's a 40-week mentorship program that now, because of COVIDs and things like that, you can either do 40 weeks all online or 40 weeks online and then come to Adrian twice and actually do a lot of your hands-on stuff here. But it's the ultimate enchilada. It's not for everybody. It's not for everybody. And but if you want to understand the truths of human movement and come up with the most powerful strategies that allow you to have a zillion techniques, it gets kind of fun. As you were going through the tweak, I thought a webcast that some people might get a kick out of us, a webcast we did on the power of tweakology and a jumping jack. So just have somebody do a jumping jack and say, that's good. Can you do another one? And usually they can. And then can you do another one? Usually right around 3 or 4, they get stuck. This particular thing on YouTube teaches you how to do over 1 million jumping jacks. Now I exaggerate a lot, but that's not exaggerating. And not only 1 million jumping jacks, but what to call them. But not only what to call them, why I would do that jumping jack for a golfer and that one for a thrower and that one for a walker and that one, because we just take a thing called jumping and arm swings and say, there's no rule, you got to stay in the frontal plane. So let's start tweaking this sucker. So you see all the varieties of tweaks, and when you see them come together, you go, yes, in 40 minutes, I learned a way to do 1 million different jumping jacks. That's the power of variability. Because if you're out on the field and you have to do something that kind of feels like a jumping jack, like you said, it's never going to be the same 2 times in a row.
Right.
Ball's going to go a different place. The defender's going to be a different place. My footwork's going to be different. So have I taught the proprioceptors as many variables as I can is the real question in training and conditioning. Have I given you every opportunity to be successful in everything that I think you're going to have to deal with when you go out there into the real world? And if the answer is I'm giving it my best shot, then you're probably climbing the right tree.
Love it. Brian, give us your couple takes, maybe a couple takeaways from your time in the GIFT program.
Gosh, so many. Again, starting with 3D maps, the specificity of the transitional zones and working from there. I think, there's, now I just have so many ways to attack issues and problems. Mm-hmm. Now it's almost like endless,
That's fun, isn't it?
It's very fun. Yeah. I don't care who you are, I'm going to be wiggling your big toe when you come in. If you got a headache, and truly, and I know this is a chiropractic, and there's a good chance, for example, if you come in with low back pain, I'm not going to touch your low back. I just don't have to. Mm-hmm. If I just improve foot mechanics, hip mechanics, most of the time I'm kind of done there, but I'm going to go upstairs to your T-spine, get better scapular motion, and it's amazing the difference. So if you are treating based around pain, there's a better life. That's all I can tell you. There's a much better life for you out there. You'll love your job so much more. And it's kind of cool because They come in with complaints. It's not like I'm not paying attention. I do, but I don't really care that much because your body's going to tell me. And I can start to read it, and especially I can feel it. And it can't lie to me. I mean, it really isn't going to lie to me.
Nowhere to hide.
Carol Levitt, one of our favorite people of all times, he said, he who treats the side of pain is lost, and more importantly, so is his patience. So I think if I can take anything away from this conversation, we're all functionalists, I guess, is what we would call each other. So we care about people in pain and their pain. It's real. But at the end of the day, we got to do things that are going to make long-lasting changes.
Right.
And I think we all share that passion. And I can feel the passion for both of you, too, just meeting you this weekend.
And Doug.
And Doug.
Yeah,
absolutely.
great meeting you, Doug.
So Taylor's here as well. So I think to close, I just think thank you for welcoming us into your space. It was awesome. Thank you, Brian, Jason, for taking care of us and for doing the audio and video and stuff. And I can't wait to have more conversations. I think we got some other cool stuff in our future that we didn't get to. Yeah, we just really appreciate your time and your contributions to the movement industry, the physical medicine industry, and all the above. So,
Father of function,
yeah,
Gary Gray.
I'll tell you
what a
what,
pleasure, man.
The honor,
Great job.
The honor is ours, it really is. When somebody's kind enough like you guys to come in and hang out with us and just talk about what we're all trying to do to just help make the world a little better place and enhance the lives of others, it just, for us, is an honor that you guys care that much and let us kind of jibber jabber a little bit. So
absolutely,
thank you.
Brian, thanks for hooking us up, for setting it all up. We really appreciate it. And with that being said, guys, I think just stay passionate. I think if I could take anything from it, just stay passionate, stay curious. It's another common thread in our podcast. And assess. Keep obsessing over assessment because at the end of the day, that's what's going to drive.
And I mean, you talk about a real McCoy. You don't see any passive modalities around here. You don't even see a table. I mean, you talk about, this is true function here. So, yeah.
This is it. So, anyway, thanks for tuning in, guys. We'll have links in the below for all the Gray Institute stuff for the MPI seminar in October. And stay tuned for next one. Good luck with patients. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.